November, because you're going to have to see what happens as those things spread from one person to the next. So we'll see how that plays out. But I'm with you. A little discouraging that it popped up like that, but we've been up and down like this. It's kind of like a yo-yo, and we'll just have to see how the next day goes. And what we always say is we'll know more in 2 weeks than we know right now.
Yeah.
Hey, we've got some really great guests with us today. We always do, but join on our left and my left, and a return visit is Dr. Mario Castro. Mario has been helping to spearhead many of our trials here in his role as the vice chair of our clinical trials unit, and really an important leader at KU, and has done a great job bringing these trials in, the HERO study, a vaccine study, and now a therapeutic study. So we're anxious to learn more about that. Also joining us is U.S. Army epidemiologist John Rule. He's going to talk with us by phone to share his expert opinions on the current spread of the virus, as well as some of the confusion about how the virus spreads. Here's what I know, Hawkeye. People in hospitals are safe.
Yeah.
And we've said this again and again. Hospitals are the real hotspot, right? For example, you mentioned we have 25 patients. Those folks are in a COVID ward, or they're in an ICU ward.
Yeah.
What we're not seeing is a lot of spread from that ward to our staff.
Yeah.
And so we know that if we do follow the rules of infection control, that actually those rules do work and they do help keep us safe. And so I think that's the bottom line out in society.
Yeah.
If you follow the rules, you have a much better chance of staying safe.
Yep. And to your point, we know that there was a publication looked at 2 medical centers, I think, up in Wisconsin. There's another publication looking at 10 or 11 academic medical centers, and all of those show that the seroprevalence, or the evidence that healthcare workers have infection with the virus compared to the community, shows that the healthcare workers have a lower seroprevalence, or lower amounts of infection compared to the community as well.
Good information, I think, to help us. All right, Dr. Castro, talk to us about this new cool trial. When can I sign up and enroll? If I get sick, do I get to do it?
Great. Well, good morning. And it is an exciting time, because I think one of the things we as physicians treating these patients have struggled with is we can support you, but we don't have any active treatment. Other than on the inpatient side, we have remdesivir, we have dexamethasone, but we're really just providing supportive care.
Yep.
And so I think the key message here is that we need some additional tools for our patients and to treat our patients. And on the outpatient side, this might be an answer.
Yeah.
So this new trial that we are now active and enrolling for is called Active 2. And Active 2 comes from a series of trials that are sponsored by the National Institutes of Health. The NIH has called this Accelerating COVID-19 Treatments and Vaccines, or ACTIVE, and there's a 1, 2, 3, and 4. 2 is the only one that is going to be on the outpatient side. The treatment is going to involve a one-time treatment that you come in. You get a IV infusion over 60 minutes. The drug was manufactured from antibodies that were isolated from a patient that had a COVID-19 infection. And from that, they were able to study what exactly those antibodies looked like, and then develop these antibodies, these monoclonal antibodies, which are very pure antibodies specific to the protein, those little spikes that are around that COVID-19. That's the spike protein that this monoclonal antibody is made to. And so the early phase 2 trials look very promising. Certainly the reason we need to do larger studies is we need to figure out better how efficacious it is, how safe it is. And so this trial will enroll across the country, and we're happy that we have it here at KU in the Kansas City area. And so we do want to let everybody know this is still a study, right? So we are not going to offer active treatment. We are going to offer you to participate in a study. So you have a flip of the coin that you may get placebo as part of this. Mm-hmm. But the nice thing is, instead of staying at home and not doing anything, which is pretty much what we tell our patients.
It is what we do. It's what we have now.
We ask you to monitor your temperature.
Mm-hmm.
Make sure if you have an oxygen saturation that you check that. But now we have this potential. You could come in and participate in the study and help us advance really our knowledge about what's out there potentially as a new treatment for COVID-19 outpatient treatments.
Yeah.
And that is pretty cool stuff. And it's not like we don't do this with other diseases, so that's really important. Mm-hmm. Just update us a little bit. How's the vaccine trial going?
Well, and I wanted to give the contact number for the outpatient study, the Active 2 study. So if you are interested in participating, contact Luigi. His number is 913-588-4022. That's 588-4022. And we'll be happy to get that, get you signed up and give you more information about the study first to see if you'd be interested in participating. So getting back to the vaccine study, I'm checking my email at midnight, seeing if I can finally get going. As we know from the press, from the media, is that the trial was put on halt for an incident that happened in the United Kingdom, in the UK, of transverse myelitis. And this case was reviewed there by their ethical board, and their trial was opened. But the same process has to happen here in the U.S. And so the FDA Safety Monitoring Board is reviewing that case here in the U.S. and has not yet released us to go live. We suspect we're going to have to add some additional information to the informed consent. That's kind of what's slowing things down, I think. But maybe this next week, I'm hoping.
Okay, well, we're anxious and hope that gets going. Dr. John Rule out there, how is it going for as an epidemiologist? How's it going in your work and here and around the world even?
Hey, thanks for having me on again. I think I was on about a month ago. At KDHE, we have the same problem sometimes that the CDC has that you just mentioned about the recent respiratory droplet issue. It's about a communication and risk communication about complex matters. We recently, a week ago, or 2 weeks ago, we put out some cluster information, and we're going to update the public and be transparent. And then when we started putting out those clusters, specifically locations and businesses that had 5 or 20, depending on what kind of business they were, it got a little confusing, so we had to pull that back last week. And then tomorrow we'll be putting out updated cluster information that's a one-size-fits-all, no matter what kind of organization you are. And so that will be clear, but we just like you were mentioning at the top of the show, have the same issue. Looking at some of the data for Kansas, luckily since early August, we've been dropping consistently in our daily case rates. The one issue is that we thought, if you look at the United States as a whole, you've had kind of two mini waves, one in the spring, one in the summer. Here in Kansas, we actually kind of had a third wave within that second wave, and that started in early August, and that mostly had to do with sporting events and a little bit of early school activity. And as you mentioned yesterday and at the top of the show, you're thinking it's going to take till October to start seeing some of the effects from school, and that definitely plays out. And whenever we look at sort of a 2 incubation cycle or 4 weeks essentially, and we're only about 2 weeks since a lot of schools started. So at the earliest, you're probably not going to see huge changes in any of the overall numbers in Kansas for another 2 weeks. But for specific numbers, I know you're going out to Hays tomorrow, and in Ellis County and in some of our rural counties, if you look at a 2-week case rate, which is the way we look at it, a 1 incubation, and that's essentially a pseudo method of looking at active cases. That's not perfect, but at least it's a metric we use. And so the 14-day or 2-week case rate, you have a lot of rural counties that are starting to be top tier, and Hays or Ellis County is actually third in the state as of yesterday, and they have essentially 3 to 6 times the number of cases per their population than our more populated counties, including Douglas, Wyandotte, and Johnson, where you guys are. And some very specific other data that I'd like to point out. If you go to the KDHE website and go to the coronavirus dashboard, I know that school topic is a very important thing right now. If you go there, recently in the last 3 weeks, we added a school gating criteria on the dashboard. And under that tab, there's 4 or 5 things that you can click on. One of them is the weekly cumulative incidence, and we've done it by week. And I know a lot of school boards and schools themselves use this criteria that comes out on Wednesday to make a determination for keeping schools open next week or the week after. And so as examples for Johnson County, you guys had decreasing trend. You had about 103 cases per 100,000 2 weeks ago, and last week you had an increasing trend of 109 cases per 100,000. And in Wyandotte, it was dropping 2 weeks ago at 112, but then was increasing last week at 128 per 100,000. That gets complicated. I know that school boards have to use that metric along with the percent positivity. And the percent positivity has been somewhere around the 6 or 7% for Johnson County, and the 8 and 6% respectively for Wyandotte County. The last thing I'll mention is if you look at school absentee and what schools are deciding to do, when we started this back in the middle of August, almost all the schools were telling us in the middle of August that they're going to go to on-site. And as every week has gone on, the percent of schools that are doing hybrid or remote is creeping up a little by little. And that's all driven by their local school boards. It's all home county rule decisions. And I think that trend, as you mentioned at the top of the hour, I think that trend going into October and November, unfortunately, we're probably going to see more and more schools having to make those hard decisions to go to remote or hybrid.
Yeah, it's certainly not over yet. Well, John, thank you, and so appreciate, again, welcoming you back to the program, and so important. One last comment on this question of aerosol versus droplet. It's sort of a goofy question, because the reality is that it's a spectrum, right? If you think about it, when you cough out different things, you breathe out different sizes of particles. It's not like, well, you're small and you're big and there's nothing in between. The reality is it's a spectrum, and you have some smaller ones, you have some bigger ones. The bigger ones carry more virus and more likely to spread the disease. That's the ones we're most afraid of. But the little ones can carry virus as well, the little small droplets. It's just that there tends to be less of them on those droplets, and so you don't get as much of the disease. So again, if you wear a mask and wash your hands, you're going to do better by and large, Hawk. Whereas if you go into somebody else's breath cloud, you stay there for 15 minutes, and they're actively breathing out COVID. Or even if you go into the room, even after they're gone 15 or 20 minutes later, and you stay there for a while, you're more likely to pick it up.
Yeah, it's certainly different than...
Without a mask.
What's that?
Without a mask.
Right, without a mask, certainly. For measles, we have concerns. We've had people, we know there's been measles outbreaks. People come into our emergency department, say that happens. We don't know it. We don't identify it quickly enough. If they are in that space, it could be 2 to 4 hours that virus can hang out in that room, in that hallway. That is not what this is. We still have the droplets, as you said. Those droplets may hang in, especially the smaller ones, may hang in the air for minutes, but it's certainly not going to be hours, and they will eventually drop down to the ground. So again, the prototypical airborne virus is something like measles. This is not that. We would see it with more infections, especially in our healthcare system.
Yeah.
The surgical masks that we use would not really protect us from that. So it is, I think, but it does cause the community a lot of confusion and anxiety. It still is the droplets. It just matters really what size they are.
Yeah. Okay, Jill, let's see first if there are questions from the media this morning. All right, you're up.
We got tons, and they're good questions. I'm going to start with Brian. On a scale of 1 to 10, with 1 being a simple flu, I don't know about flu being simple, but 1 being a simple flu and 10 being the plague, where would the panel today place COVID?
Oh, that's a great question. I like the range there. And so let's say it's a bad flu year, a couple of years ago, bad flu year. Plague, okay, that's really bad. Ebola, that's really bad. I'm going to put Ebola, and those guys get a 10. And then I would actually say rhinovirus. Let's put it this way: the common cold virus.
Yes.
That one gets a 1. Where would we put everything else? Where would you put it, Hawk?
Yeah, I think it's hard to really go with the plague because it is a bacterial infection. This is a viral, so
But
certainly
Ebola would be.
Ebola, yeah, but it's not respirable. So certainly for mortality, you don't want Ebola. For this,
Smallpox.
compared to flu, smallpox, we don't want that either.
That's a 10.
That's a 10 as far as disease, and mortality. Absolutely, a third of the people can die with that. I don't really know. It is different. We have said that 80% or more of the people won't ever have to seek medical attention, which is a very good thing. But the problem with this is the clinical efficiency with which it spreads, and it spreads to those vulnerable populations. So in that case, I would really put it at an 8 or 9 or 10 at this point, knowing what we know from those populations that are older, that have the comorbidities. And again, the destruction that has happened and the morbidity that has happened with just a small percentage of the population that has been infected. But even that small percentage has led to large numbers of hospitalizations and overwhelming of supply chains and overwhelming of healthcare systems. So in that case...
And the untold story is that even if you don't die, you can be really disabled by it. So what do you think, Mario?
Well, I think it depends on, is the scale based on infectivity or is it based on mortality? And if it's based on mortality, I would put it maybe at a 6 or 7 because we now can support these patients. The mortality is quite low from this. Even amongst our inpatients, it's been 5% or less. So, it really has dropped down with the supportive care that we're able to provide our patients, and much different than when the pandemic first started.
Yeah, it was tough.
So I'd give it a 6 or 7 based on mortality.
But it's still quite a bit more than influenza, as we've seen from even
like a 1 or 2.
The first 3 to 6 months of the pandemic and the mortality in the United States compared with a whole year of influenza.
Yeah. John, what would you say?
I would support the higher range. It's hard to do this comparison, and actually we've attempted to try to put some metrics to this, and it doesn't matter what the metric is, as was just mentioned. I don't know if we're going to know that answer for another year, because I don't know if this is only about the number of people who die. It could be the follow-up number of people who have some long-standing health outcomes even after this, a year or 2 from now. And we're thinking of creating a registry to try to follow the people who have had this disease, especially younger children that have the inflammation, and other individuals that have had other complications, neurologic or heart. I will also mention that I think we've gotten lucky in terms of when this struck us in the Northern Hemisphere, because the sun has been helping us produce a lot of vitamin D, decreasing our likelihood of having severe health outcomes. And I'm afraid that now we just hit the fall equinox, and as our third wave goes through the fall and winter, the average distribution of people getting out in the sun and the amount of UVB rays exposure is going to drop precipitously all the way through December. And so I'm worried that the high case fatality rates that we saw back in March and April might resurge again, just simply due to that one factor of vitamin D decreasing in the population.
Yeah, that's an interesting question. I'm not sure everybody's in agreement around the vitamin D question, so that's something we probably should explore in a future discussion here on the program. I'm going to rate it as about a 7, maybe an 8, and I'm going to base that on the fact that it is more infectivity, it's got more infectious, not like tuberculosis, not like smallpox, so it's lower for that. Mortality is still significant. It's certainly not influenza. I put influenza around 3 or 4, frankly, and this is just worse, and it's not just mortality. There are lifelong sequelae of this disease. You may survive it, but your life may never be the same. You may have long-standing lung disease, you have structural lung damage, structural heart damage. You may have neurocognitive problems. So it's just not influenza. And I think we consistently try to compare it because people are trying to say, oh, you're creating this. Oh, you're trying to make it about. No. This is a bad disease. It's bad. It's much worse than influenza. It's not as bad as Ebola. But Ebola doesn't, to your point, Ebola doesn't spread like this. Right. This is the problem, and Fauci said it very early on. The problem is this disease is respirable and it's easily spread and it's bad. So that just makes things a little harder. On the vitamin D question, I think that's something for us to explore. I'm not sure everybody's aligned around that. So we'll visit about that in a future program. It's a great question. We've actually had some questions from our listening audience about that before, so it's something I think we should take on.
And I would like to note, too, we are, as a health system, creating a multidisciplinary team to deal with those chronic health conditions after COVID. So that includes internal medicine, family medicine, cardiovascular disease for your heart, lung disease, as well as neurology. So we are creating that multidisciplinary team to help people navigate through that as we go on.
I think you did mention infectious disease. I think they're in there too.
Yeah, a little bit.
And I think Dr. Spikes over in Pulmonary is kind of helping head that
Yes.
up.
Leslie and I, yes.
Talk.
That's awesome.
We're excited about that clinic because I think, as you mentioned, what we really don't know very well is what's going to happen long term.
We don't.
You know, if you get a mild COVID case, that's good that you got the mild case, but what are the consequences of that long term?
And there are people who are at home with a mild COVID disease and then have sudden death, either from an arrhythmia or blood clots. We just saw one of those recently. And so this is not friendly. And even if you think, well, I'm at home, I didn't go to the hospital, you could still die from this. And so that's part of the struggle. Why we need that darn trial again.
Another trial.
Talk to us about your trial again, 588-4022. I feel like I'm pitching it, but I think this is a really big deal.
Outpatient.
Because outpatient therapy is a game changer for us in this trial.
Yeah, I mean, what we know about what this virus does to you, I mean, if we could block it, so that's what the treatment does. It blocks the attachment. It blocks it from entering into your system, in essence. If that works, then that would be, I call it an analogy. When you get a bad pneumonia and you have to come in and get a booster, an IV, booster of an antibiotic, and then you can recover much quickly. This in essence is kind of what we're trying to do with this monoclonal antibody as part of the ACTIV-2 trial.
And we really need an outpatient treatment, right?
Oh, we do.
We don't have this. We would like something like Tamiflu for influenza or like an antibiotic for a sinus infection or a urinary tract infection that we can give to people to help prevent hospitalization. There is just no good guidance or anything for treatment for the outpatient for COVID. Do we give anticoagulation or blood thinner to people who have COVID-19 as an outpatient? We don't know those things. So there is still a lot of investigation to be done on the outpatient side.
Correct.
To your point, a lot of people interested in the vitamin D question, so we're just going to say we're going to
we'll take that on
follow
in a
up
different
on
program.
that
You
because
bet.
a lot of people are asking. Cody from Channel 9 wants to know, how many people do you hope to sign up for ACTIV-2, and do they need to be actively infected?
Great question. So this first phase of the trial will be a few hundred, and then if this moves through that first phase, we call it a phase 2 trial, then it will go into a few thousand as part of the phase 3 trial. Here in Kansas City, we're hoping to enroll somewhere around 50 to 75 individuals, depending on what we can handle. And, I think if this works, we'd be excited to see what's going to do in the phase 3 trial. The second part of the question is, do they have to have active infection? Yes. They have to have be within 10 days of the onset of their symptoms. So, the sooner they call us, the better. They have to have a positive test within 7 days of the enrollment into this. So it is something that if you just found out you're COVID positive, don't wait too long because we need to get you into the trial, and it takes a little bit of logistics and testing to get in. So contact us, 913-588-4022. And that allows us to kind of give you some more information and see if you would qualify for this.
Debbie Ann has a follow-up question on the trial. She said, if I participate in the outpatient study but get worse and require hospitalization, does that exclude me from other treatments?
No. So that's a great question. What we do know is that obviously we're trying to prevent hospitalization with this trial, and that's, as Dr. Hawkinson mentioned, is really the goal behind this. And it is a trial, so you may get placebo, and you may end up in the hospital. If this is you do get the placebo, certainly, or the active treatment. We just don't know if it's going to work and prevent that at this point. So that is a possibility that it could progress, and certainly that's our target. The nice thing about participating in trial is you have ready access to healthcare individuals. So you'll have healthcare, the coordinator, you'll have access to individuals that really can guide you in terms of your outpatient treatment, things like monitoring oxygen levels, things that, give us a little bit more comfort level in managing our patients on the outpatient side.
Mario, one question would be, can you get convalescent plasma if you've been in the trial?
So great question. So the convalescent plasma trial, one is different, right? This is polyclonal antibodies that are developed to the infection itself. This is a monoclonal antibody that's purified.
Just for that one part of the virus.
So from my understanding, the convalescent plasma is only available as an inpatient treatment, right? And
inpatient treatment, EUA now.
Moderate to serious treatments for COVID-19. So this is very different. This is only as an outpatient. Convalescent plasma is only for inpatients.
So you could still do both.
You can
and I think if you were to get admitted, a lot of these trials still have, if it's part of standard of care, you can still get that standard of care medicine. So it is blood thinners, steroids, remdesivir. You should still be able to get those. I would suspect in this trial, especially since we're talking about you're getting it as an outpatient. If you are ill enough to come to the hospital, we'll certainly evaluate you, and if you otherwise meet criteria for those other adjunct therapies, you would be able to get those as well.
Definitely.
Next question, Jill.
Yes. So Sean wants to know, what is kind of the timeline for these monoclonal antibody trials,
therapies.
if there's more of them? And he wants you to compare it to the vaccine. Which is going to come first?
Which is going to be better?
Great question.
Well, it's a great question, and it is, I think, very complementary. So, we as physicians want to have all the tools to be able to treat our patients. And so monoclonal antibodies is going to be another one of those tools. You can think about the vaccine your body has to develop antibodies. Your body's immune system has to be intact. You have to think about weeks to develop that response. The monoclonal antibody, as soon as you get it, you have the antibodies to protect you. So I can think about if I'm a physician at a nursing home and I get one case, I want to start treating that case right away. I don't want to wait for that patient to develop antibodies. And so I'm going to use a monoclonal antibody in that particular case. Or think about it in your home. You as the adult, the caregiver, come home with COVID-19. Could you get on a treatment potentially to protect the rest of your family from getting this? And if you got active treatment, potentially that would protect, decrease your release of COVID-19 and protect your other family members. So I think there are a lot of reasons why we need a fast treatment per se for this, as opposed to the vaccine, which is going to take a few weeks to develop.
Yeah, absolutely. I think they are complementary. Just as you said, we know that early on in the disease course, the virus can evade our immune system. And some of the way that it evades the immune system is by decreasing our antiviral response to our immune system. If we are able to then instead provide antibodies that your body would normally make to help neutralize the virus quicker, that should have an effect. And they are complementary. They are different than the vaccine. So I think moving forward, all of these treatments are going to be useful in one time or one way or another in the spectrum of this disease.
Mm-hmm. All right, next question, Jill.
Shailene's got a follow-up question for John Rule, and she wants to know what more can you tell us about the population of patients that are getting COVID? Are they young? Are they old? Are they living closer to a city, or are they out rural? Is there anything that you can tell about
John,
the demographics?
let's parse that out a little bit. Talk to us about the urban versus rural landscape, and also, have you seen the same shift at KDHE that we're seeing in the hospital, where our average age dropped by about 10 years or so from when the pandemic initially hit?
Yes. So every week we're always sort of looking at that, as I mentioned earlier, that 2-week case rate, because that's a pseudo measure of looking at active cases. And there's always a new emerging hotspot somewhere that it seemed like they never had a problem for months, and then all of a sudden they did. So where there's the most recent county or cluster of counties, that seems to be a brand new hotspot every month, it seems like. So at first it might have been Wyandotte and Johnson, and then it shifted to Sedgwick, and then it shifted out to like Southwest Kansas with the meatpacking plants, and then it maybe shifted back to Wichita again or something. So that the geographic spread is different always. It's just constantly moving. The age distribution, I'm wondering if the age distribution is decreasing, and we're noticing that too. And if you go to the dashboard, the KDHE dashboard, you can actually look at that percent breakout by all sorts of metrics. And it's if you click on the dashboard, it's under what's called case characteristics. So yes, there are a younger group recently, but as I mentioned earlier, we're starting to see clusters centered around universities, schools, and sporting events, and specifically child sporting events. So I think early in the spring and summer, most kids were at home not doing anything, but then as this has trended on through later in the summer, early fall, it's now obvious that kids are getting out more. So that's shifting to the younger population. But, we still have our problem areas. We still have nursing homes that have issues. And I saw a question yesterday pop up about is KDHE and or the CDC pushing for long-term care facilities to be tested regularly? And the answer is absolutely yes. That's led by CMS, and CMS is actually coordinated at the federal level to get testing equipment into every long-term or most long-term care facilities to do regular testing of the workers, because if you think about it, it's really the workers that are out exposed and then bring the virus in. And so they are regularly tested. And then anytime there's even a single case in a long-term care facility, we treat that as an outbreak and go and test the facility, even if we don't suspect that amongst the other 100 or so occupants. So we still have obviously new individuals like the young, but the elder or the long-term care facility is still something we actively pursue.
Yeah, I think one of the stories of this trial will come to you next, Mario, is that the pandemic is that anytime people are together, we see an outbreak. Whether it's a meatpacking plant, whether it's a nursing home, whether it's schools, whether it's colleges, whether it's a church, people who come and congregate together for any length of time, if someone's positive in that, and roughly 1 in 100 or maybe more, maybe 4 or 5 in 100 right now are positive. So if you have a large group of people coming together, they start sharing stuff, especially if they're not masked. Yeah. And it's that combination that constantly gets us in trouble. So the more you can stay in smaller groups and wear a mask and stay distant, stay outside, the less likely you are to spread it.
Now, the other point I want to bring out about the elderly is the elderly are almost all of our deaths. 4 out of 5 deaths that have occurred from COVID in the United States have occurred in the age of 65 and older.
Be careful here now. I'm treading on 60.
Yeah. So when grandma and grandpa are sick with COVID, that is a high-risk group.
Yeah.
And so again, I'm here to talk about the COVID vaccine and the monoclonal antibody, but those are the patients I want to vaccinate first. Those are the ones that I want to treat first because they have the highest mortality risk.
And that's certainly a challenge.
Yeah, absolutely.
Okay.
All right, got 2 or 3 more.
2 more questions. 2 more.
2 more? Okay, one of them is, we have a person who says that at their church they're allowing singing now as long as they wear a mask. Is that safe?
Singing while wearing a mask. Man, that could help me if it was really a thick mask and nobody could hear me.
Right.
But I don't know about the people in choir hawk.
I would certainly feel better about singing with a mask on, especially, again, it's either a surgical mask or the 2 to 3 layer cotton mask, something that most people are probably wearing. I think, I don't know that there's been any experiments about that. There's no data, but it's certainly better than singing without a mask.
Yeah, it's probably less likely to spread, Mario. I mean, from a pulmonary standpoint, It would help some of those secretions get trapped, I'm thinking.
Yeah, I know. I definitely would support it. I certainly, when I've been in church, I've noticed that everybody's wearing a mask, and that's great.
Yes.
Because then, we do need to have be able to congregate. We need to be able to get together for things, but we need to do it responsibly. And I think as long as you're seen and wearing a mask, I think that's responsible.
Probably better. I would say this. If you have chronic health conditions or if you're older, I wouldn't take the chance. I'd watch it online and let the people congregate and sing, and you can sing right along with them. And the good news is nobody will know if you're off key. But I do think it's really important to assess your personal health risk, weigh it against that need for being around people, because that is important. There are a lot of mental health aspects of this. Talk more about that in just a moment.
And I guess last question.
Yes, ma'am.
Donna wants to know, she's really concerned about the higher rates in states that are in our region, and she points to Iowa. And she wants to know, how's that going to impact us here?
Well, first of all, Iowa and Kansas, Missouri are all pretty darn high, John. So let's talk a little bit about that. How does Iowa affect us?
Yeah, so she's absolutely correct. What's interesting is, again, we always look at it not only within the state, outside the state. So the top 10 states happen to all be in the Midwest. It goes North Dakota, South Dakota, Oklahoma, Wisconsin, Arkansas, Iowa, Missouri. Missouri's 8th. Kansas happens to be 13th on the list, so the Midwest is not doing so well. The way we try to look at that is we do put out the travel restriction, and again, we're trying to be transparent. We don't update that but every other week. We just updated that this week, and the metric we use is if another state's rate per 100,000 is 3 times or higher than Kansas's rate, then we say, okay, we need to put on some sort of quarantine travel advisory. We haven't had that in the last month simply because, as I just mentioned, Kansas is 13th. And so the higher Kansas rate is, the less likely any other state will be that much higher than us. But Iowa happens to have, it looks like 318 cases per 100,000 over the last 2 weeks versus Kansas at 242. So those numbers, that's only 1.3 times higher than Kansas. That isn't significantly higher. I can tell you that there's specific locations within Kansas that have 6 times higher rates than what we would have that you see in Kansas City. So we're humans and we're mobile, and that's the problem is we love to mix together. And so I don't know if Iowa or Missouri are necessarily the specific problems. It could be out of our own backyard.
Yeah, I think that's exactly right. You could go do that at the grocery store or at a Chiefs game. Watch out for those Chiefs games. But go Chiefs!
Yeah.
Hawk, any thoughts? Anything you want to add to the Iowa question?
No, I agree. And Dr. Birx, when she was here, definitely did state about how it looked like things were moving from the south up through the north, and we were just lagging behind them a little bit. It certainly has played out to be that way, so I would kind of support all that.
All right, so final thoughts for today. John, final thoughts?
As I mentioned a month ago, KDHE, we meet regularly. We're meeting with a lot of other organizations, including the state health department, the state education department, since schools are come back. And I'll give you a little kicker down the road here. In the next month or so, our immunization lead is doing a coordination with the CDC. The state of Kansas is having to get together our playbook, and the policy and the directed CDC recommendations of high-risk priority groups is essentially being set at the CDC federal level. And, of course, the state of Kansas has an advisory board that will make pretty much parallel recommendations. And so as that vaccine gets approved here in the next couple months to the end of the year, we don't expect a whole lot of vaccine coming our way until later, but as it comes, we will be shifting that to high priority groups. And as soon as we get any amount of vaccine, just like we had with remdesivir, and we've been distributing that, the same will be with the vaccine. We will not be holding on to that. The second we're able to get that out in the population and the high-risk groups, that's going to be happening.
All right, thank you. Mario, final thoughts today.
Well, I do, since we're talking about vaccine, I do want to put
Go for it.
plug. If you're interested in participating in our vaccine study, again, we anticipate this will start enrollment in the next week. Please contact Shelby at 913-574-3006, 574-3006. We have over 8,000 individuals interested in
That's
participating
impressive.
in the vaccine study. As John mentioned, we are going to do prioritization of enrollment. We are looking to really get our elderly, to get our minority populations that are at high risk, to really get the vaccine first. But put your name on the list. Get in there. Contact Shelby at 574-3006.
All right, Hawk, final thoughts today.
Yeah, we really do put a lot of time and effort into getting you the right message and the right education, and understand that some things aren't always black and white, but if you can remember the broad concepts, and one of the concepts is the virus is out there, so act with knowledge that you know it's out there. The other broad concepts are those things that we've continued to talk about. Distance is better, wearing masks is better, avoiding large crowds is better. And if you can understand those concepts and treat that and use that in your daily life, you will be able to reduce your risk of getting the disease as much as you can. So.
Yeah, I think that's the best advice, because the one thing we will always avoid doing on this program is we will not politicize it. We talked before, and I think all sides are guilty of this. I call it flapjacking. You just kind of flap your arms and you jack with the truth, and pretty soon you don't know what you just said. And we try to avoid the flapjack scenario here. Hey, tomorrow, we're going to be on the road in Hays, Kansas. The virus is spreading in smaller communities. We'll be talking more about that with hospital administrator in Hays, Eddie Herman, and Dr. Heather Harris, who's a medical director at Hays. Here in the studio, though, will be emergency room physician Dr. David Lisbon. If you remember, David's been on the program before. He does a great job. He's going to update us about the different waves of the pandemic and how it's kind of affecting different elements of society. And, of course, Hawkeye will be right here as well. So good to have everybody here. I want to say a special thank you to John for being back on our program today. John, we're going to talk about vitamin D, and we're also going to talk about vaccine distribution, because that's going to be an important topic when we get to it. You got to come back for that one,
right,
Dr. Castro. And always a pleasure to have you back here. It's great to have you here at KU and Hawkeye, of course. Hey, a couple of cool graphics out there. Look at that cool guy in a Star Trek mask. Our senior health and safety specialist presented me with this mask. Apparently lots of Trekkies here at the health system are wearing those. And why shouldn't they? Because they can look so darn cool. And, after all, what's the motto from Star Trek? Live long and prosper. Perfect for the pandemic. Elena, I hope I'm saying your name right. My daughter's name is Ilea. Everybody gets it wrong, so I'm going to say it's right. Elena masks up to get the kids the flu shot. Her daughter's onesie reads, "I'm too young for a mask, so please keep your distance from my mommy." Hey, good advice. Listen, folks, the pillars, they are all there. They've been there since the first day of this pandemic, and we are right here to broadcast and talk to you. Wear a mask, stay socially distanced, be cool like Star Trek, and get out there, have some fun, but do it when you're not around a bunch of people. Go to the woods. That's where I like to go. And remember, throughout this pandemic, the one thing we've been able to close every program with, and it's still true, there's still no place like home. Stay safe, live long, and prosper.
Thank you.